Hi, everybody. I'm Megan Haupt. I'm Chief of Staff for the National Association of State Mental Health Program Directors. Welcome to episode 183 of the 988 Crisis Jam. We're going to focus on crisis services supporting care and early psychosis. Really excited that Dr. Yoviene Sykes is going to be our feature presenter. I did want to comment on the opening video of Dr. Shaw talking about the Dire Crisis Center. What an incredible video. We'll have more comments in just a few minutes on that, but just the team it took, the relationship, the trust, everything that Dr. Shaw talked about was just extremely inspiring. Dr. Shaw, thank you for your leadership. Moving to, this is how you register for the Crisis Jam. If you ever want to share with your colleagues on how to register for the Crisis Jam, you do need to register. Everybody gets a personal link. You're the only one that should use that link. There are videos and past materials on this website page. Again, past episodes. And this is the latest crisis news. Really, this is just amazing. This picture took place at the Global Leadership Exchange, which took place in the Netherlands. And that the person on the left is Queen Maxima of the Netherlands. And of course, there's Dr. Miriam Delphin-Rittman and Dr. Everett there and her team. Just what a wonderful exchange that was. And that that Queen Maxima could attend portions of the Global Leadership Exchange. Thank you. Now, this is a story out of Politico where crisis line contacts are up 80% 2 years after the 988 launch. This is so amazing. If you look at the jump from May 23 to May 24, you're looking at, just even from the beginning, like 242,000 contacts of that increase. Now, the other findings about this are the call volume has grown in all states since the 988 launch, but the growth rate has varied widely among states. Idaho had the lowest growth rate from 2022 to 2024 at 24%, and Oklahoma had the highest at 185%. And they're still exploring exactly where that volume is coming from, but it is quite amazing and could point to much better access and diversion from emergency rooms. So they're checking into that. Okay, next slide. And this is a report coming out of Mental Health America. It's the state of mental health in America. And there are different aspects of this report that come from a SAMHSA survey. That survey is going through kind of a name change, but it really focuses on mental health and substance use. And so this is consolidated information. So just wanted to let you know that that's available, and the link is in the chat. Next slide. Great. And this is a Washington Post article on, if you were on the pre-show, Dr. Shaw was a speaker and was integral to the Dire Crisis Center in Prince George's County being opened. It's just fantastic. It's in Maryland, and it's aimed at minimizing lengthy wait times at hospitals. So again, thank you, Dr. Shaw. All right. So this looks a little boring until you see that star, 2,248 page. I think it's a proposed rule. Is it a rule or a proposed rule? Proposed rule. So it's a lot of pages, but it is fascinating reading. We encourage you to stay up at night to read it. And it is on the physician fee schedule and other changes. So we are going to go straight to our trivia hot seat with Dr. David Shern, who is the Senior Public Health Advisor for NASHBID and a wonderful colleague. So Dr. Shern, if you could come on, the question is, And Dr. Shern, this is not easy, but it'll be fun. Are you on?
Yeah, I am on. Thank you for prompting me because I'm trying to read the questions, not to embarrass
Okay,
myself
I'll
too
read it to
badly.
you. No
Go
problem.
ahead. Yes.
Okay. Addressing the country's behavioral health crisis continues to be a key priority for CMS, the Centers for Medicare and Medicaid Services. In support of the president's whole of government strategy, CMS is proposing several additional impactful changes in this year's rule. Okay. Which of the following is not included in the CMS physician fee schedule proposed rulemaking? So everybody, please put your choice in the poll, not the chat. And David, wishing you luck. A is new payments to assist people at high risk of suicide or overdose. B, separate payment for safety planning and follow-up. Comments on mobile crisis teams and peer services. Or D, comments on crisis stabilization units and urgent care. So David, if you just want to, you can wait to see what the poll of the audience is. You could talk through what you're thinking. We know you read at least half of this rule. So what do you think?
I was mentioning that I did manage to get through the first 1,000 pages last night. And then I went and watched our phenomenal women's gymnastics team get the gold medal. Yeah. And so I don't think I got to this part of the report, but
Sure. Yeah.
if I was thinking about what would be most what would be least likely to be in the report, among these four things, all of which are very important components of crisis response, I think I would go for a new payment to assist people at high risk of suicide or overdose. It would be great to have that, but my guess is that's not in the report.
Wow.
I mean,
and look at the
can,
audience,
yeah.
David. Look how split they are.
Yeah, so everyone was guessing. I think probably only one or two people actually have read the proposed rule. So shame on you guys.
So you could phone a friend or you could keep your final answer.
I think I'm going to stick with A.
All right. All right, let's take a look at the answer. Okay. So when we were practicing this answer completely surprised me because I went with the answer that you did, David. And on page 388, under a section on treating behavioral health conditions, CMS solicits comments on payment for services furnished in settings, including crisis stabilization units and urgent care centers. However, there's not a whole lot on mobile crisis teams. And apparently peer services are named, throughout, but not a lot of mobile crisis. If we go to the next slide, there's kind of some summary on page 390. You'll see that I have these special glasses for reading, so I move my head kind of weird. But anyway, some examples: what kind of services do crisis stabilization units provide? Do crisis stabilization units provide services similar to those described by the psychotherapy for crisis codes? And I know you're very into codes, David. You've done some great work on that. Does the definition of crisis stabilization unit vary by state? And if so, what are the variations and similarities across states? So this is just on page 390. Note that comments are due September 9th, and that there are people on this call that are working collectively to provide comments on this. David, any thoughts?
No, I'm heartened by the fact that we're getting the kind of prominence that we are in the CMS proposed rule. For many of us who've worked in this field for many, many years, we're now coming to the point where finally the importance of mental health and substance use conditions and appropriate early response for people is getting broader and broader recognition. So I think the fact that that I was wrong in terms of my guess, but the fact that these comments and components are in this report or in this proposed rule is very heartening. And I think it's part of a general move we have in terms of really featuring behavioral health issues more prominently as core to health overall.
Yeah, great. Thank you. We think it's a great move too. So, all right. Thank you so much, Dr. Shern. Really appreciate it.
Welcome.
All right. We are now going to move to Laura Yoviene Sykes, Dr. Laura Yoviene Sykes, to talk about crisis services, supporting care in early psychosis. Dr. Yoviene Sykes, it is so wonderful to have you on. If you could just take it away.
All right. Thank you so much. I'm really excited to be here at the Crisis Jam. So in addition to being a clinical psychologist in this area of early psychosis, I'm also a family member of someone with schizophrenia. And so being able to talk about this work, especially how it integrates with the mobile crisis system, is really important to me in a lot of different ways. And so the work that we'll be talking about is the STEP Learning Collaborative is where I'm the director of, and it's a public academic collaboration between the STEP program at the Yale School of Medicine and Connecticut's Department of Mental Health Services and Connecticut's Department of Children and Families. And so here you can see we have an ambitious outline for the next 15 minutes. And so even if we don't cover all of these things, I wanted to make sure that the info and resources were available for folks to reference later on the recording. And we'll be sure to put the slide deck up on our STEP Learning Collaborative website. So I'll be attempting to cover some basics about what is psychosis, just to make sure we can level set with everyone in the audience here. The crucial piece here would be talking about why are crisis services a critical link for this important population. I'll give you an overview of what treatment looks like for early psychosis, kind of the gold standard of care, coordinated specialty care. And we'll also talk about early detection and the Mind Map campaign. And then I'll just give you some ideas about how we are engaging key stakeholders in early detection campaigns in Connecticut and how that might be a model for other states in the country. And lastly, be leaving you with some helpful resources. So I imagine many folks in this audience are familiar, but just to make sure we're on the same page, when I say psychosis, what am I talking about? It's not necessarily a diagnosis, but rather it's an umbrella term that describes a set of experiences in which people have difficulty telling what's real or what's not real. And so psychosis most frequently occurs as part of a mental health condition, such as schizophrenia or schizoaffective disorder, and it can include a variety of symptoms that are outlined here. Most commonly recognized might be hallucinatory experiences, right, where we might be seeing something, hearing something that's not there, but it can also impact taste, smell, and other tactile perceptions. Folks might develop delusions or fix false beliefs that can take on a number of forms, ranging from things such as believing things that could be plausible, such as, my partner is cheating on me, to something that's bizarre or unrealistic, such as there's an alien who's implanted a chip in my brain. Other common symptoms of schizophrenia and psychosis are listed here. And you might also see, if you're trying to identify someone, you might wonder, there's a significant drop in their functioning. That's what a family member or someone around them might see it, because sometimes these experiences are happening more internally and aren't as apparent to those around them. So you might see someone struggling with work or dropping out of school or withdrawing from their friends and family. And if we click ahead, I just included some helpful questions for anyone who might be staffing a 988 line or other crisis response thing about how to get at these symptoms of psychosis. And we have a helpful tip sheet that we'll reference at the end. So next slide. It's just important for folks to know that psychosis is more common than you might think. In fact, 3 in every 100 people will experience psychosis in their lifetime, and about 1 in 100 will go on to develop a more chronic schizophrenia spectrum disorder. And psychosis doesn't discriminate. It does impact any race, gender, sexual orientation, religion, socioeconomic class. Although there are certain risk factors that can put some folks at greater risk, this can happen to any of us. And so psychosis, what I'm going to be focusing on, and for you to kind of orient our age range here, it usually develops in adolescence or young adulthood around the ages of 16 to 25, tends to be a little bit earlier in young men than in women, with the peak age of incidence being at about 21 years of age. And you might hear us, and you'll hear me throughout the rest of the presentation, talk about first episode psychosis. And when I say this, I'm simply referring to the first time or the first few years since the onset of the illness. So at STEP, we consider first episode psychosis as within the first 3 years, but it varies about how folks define this in different settings. Next. So before I get into the care, let's dive right into it. Why are crisis services so critical for early psychosis? As we'll discuss throughout, early identification and treatment in psychosis is key. The earlier that someone gets care, or the shorter the duration of untreated psychosis, or DUP as we refer to it, the better the long-term outcomes for the individual across a variety of domains. And so the World Health Organization recommends that the time, or the DUP, duration of untreated psychosis, should be about 12 weeks or less. Unfortunately, the average in the US is 72 weeks and above, and really ranges across different settings. So we know that this is an area that needs to be improved upon, and that getting folks into care is as quickly as possible is critical. Unfortunately, when many folks do enter care, their pathways to care in psychosis can oftentimes be traumatic, be triggered by aversive events that might often involve the police, unnecessary criminal justice involvement, emergency room visits, and involuntary psychiatric hospitalizations. And although these things can be done with a kind of a soft touch, and we'll talk a little bit about that, and I think, as folks know, the care that a 988 call center or a mobile crisis response team can take. The goal for us is really thinking about making that pathway to care as rapid, but also as humane as possible. It's so crucial to have this kind of soft engagement to help folks have a good experience with the mental health system from the onset. And so this is where 988 and other crisis services are so key, as unfortunately many individuals experiencing psychosis or their family members might not be familiar with psychosis, or they might face stigma or denial, but they may be willing to call 988 due to the high visibility and easy accessibility of 988 as a first contact with the mental health system. So it's really important that folks are aware of the signs of early psychosis, and then aware of the resources that they might be able to direct these individuals to, so they can get the care that they need. And lastly, given the increased risk in those experiencing early psychosis, right, this 988 and crisis services are such a key part of serving this population. And so to try to get a bit more specific about risk on this slide, I will say that actual suicide rates are hard to capture in first episode psychosis. The stats really do vary across a variety of research studies, but the consensus is that early in the course of illness is a particularly high risk time for suicide for individuals experiencing psychosis. And although this risk does decrease across the course of illness, those with schizophrenia remain at elevated risk for suicide throughout their lives. So some stats will say that individuals with psychosis are at a 12 times greater risk than the typical population. There's, again, a wide range, but rates of attempted suicide go between 25 to 50% of individuals with psychosis, and approximately 5 to 10% of those individuals will die by suicide. And again, just remembering about this kind of critical period that we know is the first 5 years since onset of a psychotic illness is really a time of heightened risk. It's also a time of heightened reward. Getting folks into treatment during this time frame can have robust impacts down the line and really impact individuals' trajectory in a positive way. So in addition to the risk of suicide, the risk of violence is something that we need to discuss. And unfortunately, there's a lot of stigma in the world and in the media that perpetuate the association between psychosis and violence. And although individuals with schizophrenia are at an increased risk for violence compared to the typical population, the majority of individuals with schizophrenia are not violent. In fact, folks with schizophrenia are actually 14 times more likely to be the victim of a violent crime than to be the one committing one. And so what we do know about that increased risk for violence is that it's highest for those who are not connected to treatment or are in inadequate treatment and also having comorbid substance use. So again, another push for this importance of connecting people to quality care as quickly as possible. And I'll just quickly note that unfortunately, this population is also at an increased risk of victimization. Next slide. So what does treatment look like? And so early psychosis treatment works, as I've said, the earlier the better. And there's a lot of research out there, including some foundational studies that have come out of the STEP program that truly support this. Treatment should ideally consist of two main parts or modules. An early detection module, which we'll talk about, which for us in Connecticut, we call that Mind Map, or it's a public education and early detection campaign. And through this type of component, you're not just sitting in the clinic waiting for young people to come to care, because we know that that's not entirely the most effective. We know that we need to kind of get out into the community, target and educate the public and other important stakeholders, such as mobile crisis providers, as well as family members and other important community stakeholders, about the signs of early psychosis and how to connect people to care. And so there have been studies, including one conducted in the greater New Haven area at STEP, that showed that an early detection campaign in the community can be effective at shortening that duration of untreated psychosis, actually cutting the time in half. And then the care itself, right? Because that early detection, all of that's happening before someone even enters the clinic. And it's something that a lot of us don't even think about. But once someone actually gets into our door, we call that kind of gold standard of care, or the evidence-based treatment, coordinated specialty care, which is a comprehensive and intensive treatment in the first few years of illness. And STEP actually completed the first US randomized controlled trial of CSC, and there's been many other trials since then that have showed a variety of positive outcomes above and beyond treatment as usual. Next. And so just a nod to the growth of coordinated specialty care models across the country. So STEP's model of care has been influential in the creation of FEP programs across the country. This is a great example of science translating into practice over approximately the past 15 years. And as of 2022, there were almost 400 programs providing CSC in the US. Next. So what is this mysterious CSC? What does it actually look like? It doesn't look all that different from care for a more chronic schizophrenia population, but STEP's first episode service model, or CSC, is comprised of 6 main elements. All of them are tailored to the individual. It's delivered on an outpatient basis, and it's based on the individual's presentation, their preferences, goals, and also the phase of recovery that they're in. And keeping in mind that all of this is amongst a kind of a shared decision-making framework. And so the key components would be offering the individual psychotherapy, medication management, family education and support is a really key component of a CSC model, especially given that many of the folks that we're working with are young people who might be living or at least supported in some way by a family member. Case management, and then access to work and education support. So supported education and employment workers are a really key part of this. And often that's a helpful way to engage folks into care. Next slide, please. So I just wanted to touch a bit on the Mind Map campaign and what it looks like. So again, it's public education and outreach. And so we're really connecting with stakeholders, both clinical and non-clinical, as outlined here. And another important part of that, after you do all that work, is making sure that you can get folks into care quickly. So rapid access to service and limiting wait times. In Connecticut, we've launched a centralized referral number that anyone experiencing psychosis or anyone around them concerned about them can call and get a rapid eligibility assessment, and then can get quickly connected to care at one of our 20+ outpatient sites across the state. Next. And so we're just going to go through a couple slides here of what an early detection campaign actually looks like. This was from the first campaign, the trial that happened in the New Haven area. We had branded material and messaging on buses. And here you can see the cutting the DUP in half. Next. Use of billboards, media spots, additionally other bus campaigns. Next. And then there's that going out and connecting with the community and connecting with other professional organizations, which is really important, including going to, like I said, mobile crisis teams, call centers, making sure that they're aware of what we're offering and the services that are available to this population. Next. And so this is just a little bit of what that outreach looks like for this specific stakeholder group if we're thinking right about engaging with crisis services. So for us, this looks like outreach to 988 operators in Connecticut's United Way, connecting with mobile crisis teams, also making sure that police departments are aware, maybe adding and consulting on some of the trainings, making sure that family and peer organizations are aware of the resources and getting their input. And so if you see below, those are an example of some branded materials. You know, we hand out cards so that people readily have available the signs of psychosis. They know the number to call. We've got flyers that are hanging up in offices across the state and in real in stores and other community spaces. Next. And so lastly, I just want to make sure that folks have resources. Our Step Learning Collaborative website, which we'll drop in the chat, perfect, has a bunch of trainings for providers, for families. There's a lot of virtual content on there. We also offer a consultation line for providers in the state. There's 3 great tip sheets, which we can see on the next page, including one developed by our colleagues at Stanford, specifically for 988 and thinking about how to, why it's important to understand and help support this early psychosis population. And then we'll also put in the chat the SAMHSA locator so that no matter what state you're in, if you're trying to connect someone to care, you'll be able to identify the closest coordinated specialty care clinic near you. So thank you so much.
Fantastic. Dr. Yoviene Sykes, that is such a great presentation. I've heard a lot about early psychosis in the past, but I learned new things from what you were talking about and really appreciate you defining psychosis as well as that look each year that the earlier we intervene, the better. And that duration, that intervention is just so important. Want to bring Wanda Joffrey on, who is the Clinical Director, Acute Crisis and Emergency Response Services for the Continuum of Care Incorporated for the Roundtable. Wanda, if you could please give us your thoughts and comments for this discussion. And go ahead and come up.
Sorry.
Great.
Hi, good afternoon, everyone. Thank you so much for having me here. My name is Wanda. I'm the Clinical Director of Acute and Emergency Response Services at Continuum of Care here in New Haven, where I oversee several of our crisis programs. Prior to coming here, I worked for 11 years with the State of Connecticut Department of Mental Health and Addiction Services for our mobile crisis team. And like Dr. Yoviene Sykes said, programs like STEP and coordinated care programs are really important to collaborate with crisis services because, you know, our mobile crisis teams are kind of the first link to treatment for a lot of these folks, right? There's some sort of crisis in the community. Mobile crisis team are called, 911 is called, and a lot of us are the first responders to be able to kind of get to the location, the situation, and assess what's going on. And so it's really good when, you know, we have the information of clinics like these. The STEP clinic in New Haven in particular worked really closely with our mobile crisis team. So we were educated on what services were offered. When they had concerns about clients in the community, they reached out to us and say, hey, these are the concerns that we are having. This is what's going on, just in the event if the family calls, so that you're very well aware, and that would help us with our assessment when going out on calls. And also, if we go out, on a call first, and then we're able to get in touch with someone who is experiencing these symptoms who could benefit from the program, having that collaboration is really, really helpful in being able to connect that person to services, because like it has been said, the earlier someone is connected to treatment, the better. So it's definitely an ongoing collaboration, an ongoing partnership, and kind of working together to be able to, to better serve those who need the work.
Thank you so much. And it's just amazing work. And I love the outreach that is, and creating those relationships. If we can, and there are so many comments in the chat, I just want people to take a look at those. And if anybody on the roundtable and Dr. Yoviene Sykes, if you want to respond to some of those, I see you responding to them. Really great comments there. And now let's move to Ken Farpstein, who is a consultant, advocate, father, and family partner at JRI in the CSC program. Please go ahead.
Thank you. Yeah, I'm Ken Farpstein. I'm going to talk quickly about my son's story, and then have two recommendations for people in the call. So my son was a smart young man, still is, was in college when his delusions started in 2012, and kept going, and then developed into hallucinations also in 2015. And around that time, I started getting involved. I started going to a support group with NAMI, the National Alliance of Mental Illness, NAMI, and found that very helpful, biweekly sessions to start learning more about mental illness, because I was so much, unaware of all of it. My son had his psychotic break in October of that year, October 2015, and then was in the hospital for a week or 10 days or so, and then in a partial hospitalization program for 10 days, and then came home to live with his mother. So I kept going to the NAMI support groups during this time, and the group leader there suggested the PrEP program, which was then a program of coordinated specialty care for early psychosis at Beth Israel Deaconess Medical Center in Boston. So I contacted the program director, Ann Fendyson, who's a wonderful person, who was able to get him an intake about 2 months later or so in March. And then we got my son into the coordinated specialty care program there. And just quickly, what was the program? There are different models, but for the PrEP model, he would go there on Tuesdays and Thursdays most of the day. He'd have a weekly meeting with a psychiatrist, the same one who really got to know him quite well. The psychotherapist was there, a case worker, a case manager overall. And the young men and women in the program, the patients, had a lot of groups that they were exposed to about improving their understanding of the illness, of cognitive behavioral therapy, and other and socialization kinds of things, nutrition. They had someone who showed them how to cook healthy meals. They played basketball at lunchtime. So it was really a very comprehensive program. So he was in that for 3.5 years, and then graduated. And now he has a job, he has his own apartment, he's really got his life back on track. And I attribute much of his recovery to the coordinated specialty care program for early psychosis that he was in. And so how did he get there? I mean, these programs are often pretty invisible. I wish there was a lot more publicity for programs like Laura's. For me, the key recommendation would be and for everyone to pretty much for, I think, almost every call that you get at the 988 line, to refer them to NAMI. So if you could put the links up on the screen, please. I would appreciate it. So that's nami.org. And at the bottom, very bottom of that homepage on the left, there's a link that says, you click on it, it says find your local NAMI. So you type in the state and then the list of all the NAMI affiliate organizations in the person's local area appear with the contact information. And they have, NAMI then has classes for parents and support groups and all kinds of activities and support. So that's really the strongest recommendation that I can make. And also for you, when you get a 988 call, that if the person is having delusions or hallucinations, that is psychosis, as my son had schizophrenia. So please use the program locator, and there's a link to that as well, if you can put that up as well, that the SAMHSA has offered. So as Laura mentioned, there are almost 400 programs across the country. They're in the map she showed, they're in 47 different states. So there really should be a program, in the state of wherever the caller is calling from. And I don't think that you need to wait for hospitalization, and you shouldn't. As Laura mentioned, the hospitalization itself can be somewhat traumatic. So if they're having delusions or hallucinations, and that's that may well be the evidence of psychosis that could well qualify them for a program like that. So that's I just really urge you to go to the NAMI website and to use the program locator wherever that's indicated.
Ken, thank you so much. What an incredible story. And so often we hear of tragedies versus access to care. And this just seems like such a wonderful way for early treatment, for connection, which helps so much with recovery and thriving and wellness. So thank you so much for sharing your story with us. And it's so great that NAMI was supportive for you as well. That's just great news. So
thank you.
So thank you. Thank you very much. And also thank you for this whole presentation in terms of what 988 can do, that it's just such a great resource when families just don't know what to do. So thank you. Great. So we're going to go to the SAMHSA update and shift it to Dr. Anita Everett. Dr. Everett, it's wonderful to have you on. Thank you.
Great. So thank you. Yes, I thought I appreciate it. I haven't been attended Crisis Jam in a little while, but I know what's happening. I keep up with it through many of our staff that attend, and I really appreciate the effort and energy that continues with the Crisis Jam and its valuable place across the nation. So thank you to all that are involved in support for this meeting. So keeping on the theme of children, which seems like what we're doing, or transitional age youth, I wanted to report out a little bit on an activity that we've been working on lately that has to do with kids' online health and safety for children and youth. And how this connects to crisis services is multiple different ways. So many do in thinking about, what we largely call the children's mental health crisis, or the mental health crisis of the day, and thinking about what is different about this generation who are currently young than previous generations. One of the things that comes right up is social media and the access that youth of that age, if American youth, have to social media. And so it is a cause, it is widely considered to be at least contributory to the causes of the increased stress that our youth are experience these days. It's also I don't have statistics on how much of the calls that are made or texts or chats that are made to 988 is based on something that has to do with social media, but I do know anecdotally that it's a very common cause for admission to an emergency department for kids, parents and kids to get in dialogues, debates, arguments about the kids spending too much time on social media or not. So it is a cause, we know, of admissions or interface with the higher level services. So it's in the air, it's around. We also, in thinking about social media, we know that adolescents, this whole age group that we're talking about today, it's starting with children really, and on up in through transitional age adults. or youth, we know there are many developmental tasks that are happening and the brains are still developing. The brain is not a done thing by the time you're 5 or 6. It keeps developing. Those pathways keep changing that are part of it. And so social media, access to and engagement with social media can interfere with some of those developmental tasks of youth, which include development of identity, how much self-disclosure a person is going to make, and what happens that a person knows about or doesn't know about could happen with what they reveal about themselves, including photographs. Their social status is measured sometimes by numbers of likes and other different things like that, an important developmental task or developmental issue. And then identification of finding people like me, which can be protective and helpful, but also problematic if that is used against individuals. So this line of work started over a year ago. It was based on a work that came directly out of the White House. A fact sheet was released that asked for a task force to be put together. We at SAMHSA, our director, Miriam Delphin-Rittman, led that together with the Department of Commerce. And we've spent the last year sort of studying the impacts of social media on kids and making recommendations. Largely, our recommendations fall in 2 broad categories. One of those is a set of recommendations that are oriented toward parents, and the other is a set of recommendations that are oriented toward industry. So the parent recommendations, I don't believe I sent that to you, but if you, the full report, which was that blue page that was just up, the full report's available on our website. If you Google SAMHSA, Kids Online Health and Safety, you'll come to the page where it is, and the full report is downloadable. There also on that page is the handout that we gave that has specific ideas in it for parents, and that was intended to be useful to pediatrics offices, to teachers, to parents directly. And it has a set of resources in it that are, again, designed to be very useful. Many of the resources and much of our work was supported by a Center of Excellence that we have funded. That also is available for public viewing, the Center of Excellence on Kids Online Health and Safety. The grantee there is, that's depicted there in that top diagram there, but the grantee in that case is the American Academy of Pediatrics and has some very top-notch national researchers that are, very concerned about and interested in looking at objectively what is the impact of social media on kids at large. So to give an example of the types of things we came up with strategies that are for parents that come out of this report, that are in the report. They include things like build a family media plan, which is a longstanding recommendation that the AAP has had. And then balance time with and without devices. So as parents, we're advising that they pay attention to taking a neighborhood bike ride or a walk or things that are involved putting the phone down. Some families, go as far as having a basket at the table, and so no one's allowed to have their phones during the table, but concrete things like that. Talk about social media with your kids. Some parents that we've learned in our journey, which included multiple different ways of inputs from stakeholders, some parents are a little bit intimidated in talking with their children about media because they're afraid they might feel unknowing or unknowledgeable about what the latest thing is in social media, or even what the latest way that you use Instagram or Snapchat or some of those things. So talking to your kids and making sure there's an open line of communication is the third of the 5 sort of those. The other thing that comes up that we recommend parents think about, or 4th of 5, is setting a good example. Probably all of us have had the experience of being out at a restaurant or, even of any kind, and seeing 4 people sitting around a table, 2 parents, 2 kids, and all 4 of them are separately on their phones, looking at their phones and not talking to one another across a dinner table. So parents setting a good example of putting the phone down, putting the media down is a really important opportunity that parents have. And then optimize, the 5th one is optimize your family's online experience, so that, maybe even there are things that you do together as a family that help kids. To the industry side, actually, many of the things that were recommended as a result of this task force for industry, and this is not a regulatory task force, it's intended to be sort of groundwork for other things, but they're interestingly very consistent with the law that was just passed in the Senate. It's for the House to deliberate, but yesterday or the day before, Senate just passed a law that it includes a set of recommendations that are oriented toward many of these activities that have to do with protecting the identity of children, being much more transparent about what happens to information about children, algorithms that children are exposed to that optimize advertisements and marketing opportunities to enhance children. And so I'll invite you to sort of look at the report for full details, but they're very aligned with what the Senate has just passed. Let's see. So in the end, we recognize broadly that one of the things that we were very concerned about is we didn't want to have the conclusion be, it's all bad, just get rid of social media and everything will be fine. We recognize that there are some individuals and some huge advances that have been made by access to the technology that we have access to, learning experiences. With regards to a sense of identity, we came across multiple different concerns expressed by subgroups of individuals, such as transgender youth, who oftentimes find community in a chat group or in a group that they otherwise would not have identity to if they were just in school or lived in a context where transgender was not, was even actually a risk for being bullied. So a sense of community is one of the things that turns out to be important. So there's categories of information and social media use that are unlawful and should be unlawful. There's categories that have to do with problematic use, and that would be use that is more difficult with saying no or putting the phone down. Those kinds of use, and then there's good use or use that can be very helpful. Let's see. Those are some of the main do-outs from the study that we did. So in some cases, it can be very helpful, and then there are clear examples that all of us have heard about, I'm sure, that where online activity has been extremely harmful for individuals, on down to invoking suicide, thoughts of suicide, and the other use case or the other scenario that you hear quite a bit about is eating disorders that were believed to be triggered by or associated with things that kids see online that they otherwise wouldn't see if they hadn't been online. Okay, so let's see. That's the activity that we've been doing on the Kids Online Health and Safety report. Megan, I'm happy to answer questions or however you wish to proceed.
Dr. Everett, thank you so much. What a bounty of information, and appreciate this resource and this report. I think it's really going to make a difference for so many, especially with the concrete recommendations you just said, even on this forum. So thank you so much, and thank you for your leadership. Great. We're now going to shift to Dr. David Shern with NASHBID, and go ahead, Dr. Shern.
Hey, it's great to be back after the hot seat. What we want to do here is feature the work that's going on in the states around implementation of the crisis system. And you can see that we've had 34 states participate, and that's about 2/3 of all states and territories. And would love to hear from the other states that haven't had a chance to feature the work that they're doing in the crisis space. And you can see those are the states in black as our nation slowly falls apart. And we get to the big news, which is the fact that the Centers for Medicaid and Medicare Services has recognized coordinated specialty care with its own billing code. And that is a big deal. As Anita Everett has often said, the services that you can get for mental health related needs and substance use related needs really depends on where you live. And like Laura said, even though we've expanded to 400 programs, we need many more. And in order for us to reach the level at which anyone in the population who's experiencing those symptoms gets that quick treatment, that wraparound that Laura was talking about, in order to do that, we've concluded that you have to be able to bill insurance, both Medicaid and commercial insurance. And what we learned in trying to implement a law in Illinois that required commercial payers to be involved is that not having a designated code from the center, from CMS, is a big problem. And so Nashville, along with colleagues, put together an application to CMS. We had great support from SAMHSA, from NIMH, and from the community generally. And in October of last year, CMS recognized coordinated specialty care as a thing that needs to be covered fully as a team. And the fee-for-service reimbursement will not cover the team-based service. And so we can see that we have H2040 and H2041. One is a per member per month rate, and the second one is a rate based on encounters, but those encounters are a prospective payment system that covers the full cost of the program. So we're very excited. We're in the process of rolling this out now, getting states to actually calculate the rate associated with the codes. And we think this will make a big difference. It will be of relevance, obviously, to the crisis system in that the more programs that can be supported around the United States, the greater your resource availability will be when you encounter people who could benefit from that kind of a program. So we're excited about it, and we're going to continue working on trying to get this universally available in the United States. So Megan, back to you.
Thank you so much, Dr. Shern, and appreciate your work on that. We're now going to shift to Peer Central with Arrow Foster. Arrow, please take it away.
Thank you, and thank you for inviting me back for this second episode. So we've discussed today the inclusion of peer support specialists in the services that we're discussing, but this cannot happen without a robust peer support specialist workforce. So today I want to talk about a critical issue and the gaps in workforce development and retention for peer specialists, and how two bills currently in Congress can help address some of these issues. As you know, peer support across the country goes by a lot of different names: peer specialists, recovery coaches, peer navigators, many, many more. This variety in job titles makes it incredibly challenging to track workforce needs and develop consistent training and retention strategies across these different states. So I'm going to begin just by highlighting the essential role that we play in the mental health system as not just employees, but as a lifeline for many people living with intellectual and developmental disabilities and behavioral health challenges. We provide a wide range of services, from enhancing independence and community inclusion to coaching on self-expression and assisted living, daily activities. What sets us apart from the support roles such as health aides, home health aides, psychiatric techs, behavioral health techs, and personal care aides, those are the current Department of Labor standards, occupational classification codes used to track our work, is our unique focus on promoting independence and community participation. And this requires a distinct set of skills and experiences that only peer supports can provide. So despite this critical role, we are facing significant challenges in hiring and retaining peer specialists. Turnover rates nationally are alarmingly at 43%, with full-time vacancy rates increasing dramatically. It not only affects the individuals receiving services, but hampers the overall goal of the programs in which we work. When turnover is high, personalized care suffers and individuals struggle to reach their goals. So to address these issues effectively, we need better tools to understand the labor market for peer support specialists specifically. This is where Senate Bill 1332 and House Bill 2941 come into play. These bills call for the establishment of a discrete standard occupational classification for peer support specialists, a unique one, not mixed in with the others. And by doing this, we can better interpret labor market shortages, collect accurate data on turnover rates, and develop targeted strategies for the development of workforce retention. So it's not just about data, though. It's about recognition and standardization. Current classifications do not represent the unique role that we play. The new SOC code will correct this, giving peer support specialists the recognition we deserve for this work that we do. Furthermore, aligning these with other classification system ensures consistency, enhancing credibility, the professionalism of peer support specialists. It's crucial for developing standardized training programs and retention strategies that can be developed across states. These two bills provide a strong framework for addressing these issues. They highlight the critical role of peer supports and the challenges in hiring and retention. They call for the establishment of SOC Code 31-1123, specifically for support professionals, emphasizing the need for this. So, without going into this a lot deeper, because I could keep talking for hours on this, in conclusion, I want to say that establishing these codes is a crucial step for closing the gap in the workforce development and retention for peers. They provide the necessary framework to achieve this. And by recognizing and supporting peer specialists, we enhance the quality of care for individuals with IDD and behavioral health challenges, ultimately building a stronger, more effective mental health system. Thank you for your attention to this and for letting me speak. I'll turn it back over to you, Megan.
Wonderful. Thank you so much, Eero. That's really interesting. Sounds like a great direction. We're now going to shift to Stephanie Hepburn to talk with Dr. Chuck Browning, as well as potentially Dr. Pinels. We're not sure if Dr. Pinels was able to make it, but we're on it.
Yeah.
Yay. Excellent. So go ahead, Stephanie. Thank you so much. Tell us about Crisis Talk this week.
Yeah, so we spoke about the need for national standards to build equitable crisis care. Dr. Pinels and Dr. Chuck, can you share the pitfalls of not having national standards and also some of the tools that can help?
Yeah, sure. I mean, one of the pitfalls of not having standards is we won't meet our goal of serving anyone at any time. I mean, we recognize that we want to have people not go to emergency departments when that's not necessary. But that means if we're going to take anyone into a crisis service, a crisis stabilization service, we need to be able to make sure we can meet their medical needs as well as their psychiatric needs, at least their basic medical needs. Clearly, if somebody has more severe medical needs, then emergency treatment might be indicated, but that's only going to be a very, very few people. Chuck?
Hey, thanks, Deb. Thanks, Stephanie. I enjoyed doing that article with you guys. I think I tied it to just the overall. I mean, our article was specifically about medication and medical evaluation and stabilization in crisis settings, but it's really for overall driving of care for all of crisis. That if we talk a lot about mirroring the emergency physical healthcare system, and one of the great things about that is we've had decades of data of looking at how to best support things and sharing of that data. So I think those same principles overlap, whether we're talking about medication and things like that, or if we're talking about, recovery-oriented care, person-centered outcomes, or, those types of things. So
I think the other thing that I thought was really great was that you mentioned the need for facilities to be able to address and have services geared towards both people who have challenges with mental health and also substance use disorders. And in the article, I highlighted a throwback article with Nick Margiotta, who said he's a former police officer in Arizona, retired police officer in Arizona, and he was CIT trained, and he tried to drop somebody off at a substance use facility, and they said, no go, the person is experiencing suicidal ideation. And then also when he tried to drop them off at a mental health facility, they said, no, the person is on substances. So I thought it was so great for you to tie in all of these different issues and how it has to not just serve people medically, but also in terms of comorbidities.
Yeah, absolutely. I mean, we know that these comorbidities run together: medical, psychiatric, substance use disorders can all co-occur. We're all, people are one person, and you can't silo those issues out. And all too often the service systems have been siloed. We know that people with serious mental illness die at least 20 years earlier on average. And that's partly because of medical conditions that go under-recognized. And the difficulty in treating people with all those comorbidities that have been historic, and we really want to break that down.
Thank you so much. Thanks for hopping on with me. I'll pass it back to you, Megan.
Wonderful. Thank you so much, Stephanie. And just so appreciate your articles and the outreach and the more, I want to say simplified explanations, because when I read your articles, I just learn a lot. They feel very personal. So thank you for your work on that. Want to say next week, episode 184 will be on the firehouse model, underwriting crisis capacity. And Phil Evans will be that feature presentation. And the week after that will be episode 185 on medicated assisted treatment or MAT services. And Joy Brunson Unsubaga will be presenting on that. And she is with Recovery Innovations. So thank you, everybody, for joining us today. Thank you for the interpreters. Thank you for talking about early psychosis. This has been a wonderful theme to address. And we hope that you join us next week and the weeks after. If you have any ideas for crisis jams that you'd like us to address, please let us know. And you all have a great rest of your week. Thank you.